So our next speaker is going to be my colleague, Dr. Joe Dillon. Joe is an endocrinologist by trade. He works in our neuroendocrine cancer clinic with Dr. Oetreotide and myself and everyone else. And as Joe and Tom are both endocrinologists, so their perspective is a little different from the medical oncologist. Joe is one of the smartest guys I know, and I'm looking forward to learning all about Telotristat.
Dr. Howe doesn't know many smart guys, clearly. Anyhow. All right, I'll be talking about Telotristat Ethyl, a new way to treat carcinoid syndrome. So what I'll be covering in the talk today is basically these points. And some of these Dr. Wolin has covered well already, so I'll whiz through them pretty quickly. So what is carcinoid syndrome? What causes carcinoid syndrome? Does carcinoid syndrome matter? What are the drugs that are available for carcinoid syndrome? What's new for control of carcinoid diarrhea specifically? And what else can we do about carcinoid syndrome symptoms? So as Dr. Wolin has covered, these are the key features of carcinoid syndrome. I've got other down there at the bottom. The other might include rhythm disturbances of the heart, the pellagra that Dr. Wolin mentioned. But all of these symptoms of carcinoid syndrome are caused by hormones from the neuroendocrine tumor. So the usual statement is that about 10% of patients initially have carcinoid syndrome. Depending on the study that you look at, it's 10 to 40%. Tends to increase over time. Usually, most often, it's with small intestinal tumors, but can be with other tumors also. Usually, it's with the presence of secondary tumor in the liver. But that's not always the case either. Both with certain tumors like primary, the rare primary neuroendocrine tumor in the ovary can produce carcinoid syndrome without metastases, and we can see variant carcinoid syndromes in patients with lung tumors or foregut neuroendocrine tumors even without liver metastases. So does carcinoid syndrome matter? Any of you who have it know it does. But this was a nice study that came from the folks down in MD Anderson, looking at over 600 patients with neuroendocrine tumors and looking at aspects of their quality of life, whether that was depression, anxiety scores, how well they were doing physically, functioning, and also correlating that with how large their tumors were, whether they had surgery or no surgery, whether they were on various forms of therapy, and what they found was as follows, and I've simplified these graphics from their original paper to focus on a couple of key metrics, because what really panned out was that the more bowel movements a person had per day, i.e. the more diarrhea they had per day, the worse off they were. So the quality of life scores, whether you looked at physical function, which decreased with increased bowel movements, or anxiety and depression, which increased with increased bowel movements, or if you looked at the flushing aspect of it, again the same pattern of the more flushing, that is, the more carcinoid syndrome symptoms patients had, the worse they felt. So, what causes carcinoid syndrome? Well, I mentioned hormones cause carcinoid syndrome. Chemicals that are produced by the neuroendocrine tumor and its metastatic deposits. There are multiple hormones that have been associated with neuroendocrine tumors over the years. There are certainly over 20 of them, different neuroendocrine tumors in different parts of the body producing different hormones. The same neuroendocrine tumor in different patients producing different hormones. So quite a complex group. There are hormones within this group that have and you heard about these yesterday. There are hormones that are good for neuroendocrine tumor markers. They show you that the disease is there, but they're not known to do anything actually in terms of producing a syndrome or producing symptoms. Whereas there are other hormones which clearly produce symptoms. Histamine produces almost allergic-like symptoms, but produces flushing. Substance P, prostaglandins can produce flushing and blood pressure changes. So there are a group of these hormones which actually not only are tumor markers, but they also give rise to symptoms that you might get. I'm going to focus today on serotonin because for a very long time now, serotonin has been known to be one of the major causes of diarrhea and a major cause of some of the other features of carcinoid syndrome, although not all features of carcinoid syndrome. So it has less of a role in the flushing of carcinoid syndrome. Serotonin was actually first recognized to be the cause of the diarrhea in the 1950s. A scientist in Austria figured out by grinding up a piece of neuroendocrine tumor of the bowel and injecting it into animal models that this A cause diarrhea, and B, the actual active ingredient of the solution from the tumor, the active ingredient for about 50% of its effect was serotonin. So serotonin has a long history in regard to normal bowel physiology. Serotonin is a really important chemical in the normal bowel. It's expressed normal. Actually, the bowel is the biggest organ that produces serotonin in the body normally, and that's not anything to do with carcinoid tumors. The normal effect of serotonin on the intestine is that it stimulates the duodenum up in the upper intestine. It indirectly stimulates some contractions of the rest of the small intestine through an effect on the vagus nerve, which is the main nerve into the intestine. It stimulates the secretion of water and electrolytes into the intestine. So it does really important things for normal bowel physiology. Now, as I mentioned, the discovery of serotonin's role showed that serotonin caused essentially half of the diarrhea in that animal model. Well, there are other hormones from neuroendocrine tumors, and many we perhaps don't well understand, which cause diarrhea also. So, which drugs do help with carcinoid syndrome? And again, Dr. Wolin has covered this very well, so I'll just briefly skip through the next few slides, which are somewhat repetitive. So, somatostatin analogs, as Dr. Wolin has shown us, improve flushing and diarrhea in 80% of people. They act on those somatostatin receptors, and they're thought to decrease all hormone production within neuroendocrine tumors. This is a small sub-study from the Clarinet study, which Dr. Wolin referred to, and shows that in a group of patients who were treated with Lanreotide, there was a significant decline in urine 5-HIAA, which is the breakdown product of serotonin in the bloodstream, whereas in the placebo group there was no decline and actually an increase over time. And similarly, similar data can be shown for Octreotide or Sandostatin, either the short-acting or long-acting forms. This is just one paper from Dr. Mortel at the Mayo Clinic, showing that the number of daily stools, so the amount of diarrhea, declines from approximately 6 to approximately 2 to 3 very rapidly after taking either the subcutaneous short-acting form of Octreotide or the long-acting form of Sandostatin. So those things work really well for neuroendocrine tumors and carcinoid syndrome, but they don't work well enough. There are many people who still have very debilitating symptoms of carcinoid syndrome, despite being on high doses of Sandostatin or high doses of Lanreotide. So I think one of the breakthroughs in treatment or in pushing treatment further in terms of the symptoms of carcinoid syndrome, what you feel, has been the discovery and development of Telotristat, which is marketed as Xermelo. And this drug decreases diarrhea by decreasing serotonin production, but it decreases serotonin production in a novel manner. It's not the same mechanism as with the somatostatin analogs or the Sandostatin, Octreotide, Lanreotide. And so from the product brochure, the description for Xermelo or Telotristat is that it's for the treatment of carcinoid syndrome diarrhea. It's to be used in combination with somatostatin analogs. So this is for people who need something more than somatostatin analog, need something more than the Sandostatin and Lanreotide for their diarrhea. It's approved for adults, and it's for diarrhea that's inadequately controlled on somatostatin analogs. So how does that all work out? Well, as I mentioned, Xermelo has a novel mechanism of action. I'm losing a little bit in translation here. But let me take you back to what happens to the amino acid tryptophan. So tryptophan is an amino acid. It's part of it's a building block of protein, and this is just a slide depicting a very simplified voyage of where tryptophan goes to in the body. So you get your daily protein intake. It gets proteins get broken down into amino acids. Tryptophan has a number of possible pathways that it can go to. It can get built up into other proteins in the body, which is where most of it goes to. It can get chemically modified to a variety of perhaps important chemical substances, ending up at niacin, which is one of your vitamins, or a small percentage of it, perhaps 1%, normally gets metabolized through into serotonin, which eventually gets further metabolized and excreted into the urine as 5-HIAA. So what happens in in nets, and this is particularly focused on the carcinoid tumors. So in that situation, we have a big increase in the amount of tryptophan going down this pathway. So a lot more serotonin being produced, a lot more 5-HIAA coming out in the urine, a lot less going into niacin, which actually the absence of niacin causes the condition called pellagra, which is a skin rash and other symptoms. So under the influence of this enzyme, tryptophan hydroxylase, tryptophan is being shunted down into the serotonin production. Serotonin giving rise to the diarrhea along the way. So what Xermelo, this novel medication, does is Xermelo directly acts on tryptophan hydroxylase. And by doing so, it decreases the amount of tryptophan that's progressing through to serotonin and 5-HIAA. It allows more to go into niacin and protein. And I should say that this is Xermelo is a breakthrough medication in that it works with relatively few side effects. The concept of doing this, trying to influence tryptophan hydroxylase to decrease serotonin, is a concept that's been around at least since the 1990s, and there were papers on previous agents which inhibited the effect of tryptophan hydroxylase. However, it turns out that we have two tryptophan hydroxylases in our body. We have one in our brain, which is really important at producing serotonin in our brain, and serotonin, as many of you know from hearing about antidepressant medications called SSRIs, or selective serotonin reuptake inhibitors. You've got some concept that serotonin is actually important in your brain for maintaining you away from psychoses and depression. So the older medications actually inhibited both the enzyme in the brain, which gave rise to serious depression, and inhibited the enzyme in the body, which helped with the diarrhea. Suffice it to say, those drugs never went any further. Xermelo is a drug which does not cross the blood-brain barrier, and therefore is not associated with the psychological effects of the previous agents, but it is associated with the benefit in terms of diarrhea. So I'm just going to show one sort of data slide here, and this comes from the major paper which paved the way for FDA approval. Dr. Kulke from Boston was the lead author, and others in this audience were also in the author list. And basically, this is one of the data slides, but showing the change in number of bowel movements per day, whether on placebo or two different doses of the Xermelo or Telotristat. 250 milligrams 3 times a day is actually the FDA approved dose, and the dose that your doctor would usually prescribe for you. Now, more than just decreasing the bowel movement frequency, there were also effects on urgency. There was effects on how liquid the stool was. So there were clear effects then on satisfaction of people who were taking this medication. They were able finally to have more control of their bowel issues, allowing them to get out and about and do what they wanted to do. So there are some things to remember regarding Xermelo or Telotristat. One issue is that it's best taken with food. And it seems it may be problematic for some folks with neuroendocrine tumors because many of them don't have their gallbladder and have problems with fatty food. But actually, the amount of Xermelo in the bloodstream is over twofold higher if it's taken with food and with some fat component in that food. Issue number 2 is there is an interaction of short-acting Octreotide and the absorption of Xermelo. So if you take Octreotide before Xermelo, you will decrease the absorption of Xermelo. So please use the Octreotide at least 30 minutes after taking the Xermelo. A very important concept also is not to give up too early on this medication. The onset of the activity of Telotristat or Xermelo can be anywhere from 4 days to 68, 70 days. So that's averaging anywhere from 3 to 6 weeks, and can take up to 10 weeks. So I do try to keep people taking it for up to 10 weeks to make sure that to be certain that we've given it an adequate try before leaving it aside. In about 30 to 40% of people, it won't have a benefit. So there are those as well. Discontinue it if constipation develops. Side effects are mostly, the side effects that I hear about are mostly gastrointestinal side effects. I think some of these side effects are particularly evident early on, and if there are side effects, I get people to start a little slower, taking 1 tablet a day rather than 1 tablet with each meal, etc. Because for the majority of people, they will get a benefit from this medication, and those people will be more satisfied with the result. Now, just briefly to compare then Xermelo with the somatostatin agonists that Dr. Wolin covered, they both decrease serotonin, they both decrease diarrhea. Octreotide and medications like it decrease other neuroendocrine tumor hormones, which can sometimes be very important, whereas Xermelo is strictly a serotonin-focused medication. There's a decrease in the flushing component of carcinoid with the somatostatin analogs, whereas it's maybe occasionally with Xermelo, but not impressive. And this just tells me that the flushing of carcinoid syndrome, the serotonin is only a minor component of that. Now, there's a lot of interest and research going forward about carcinoid heart disease, because serotonin is known to be a major cause of the carcinoid valvular disorder, and therefore there's a lot of interest in looking at that in terms of research, that there may possibly be an effect on heart disease. As Dr. Wolin demonstrated from the Clarinet study, for example, the somatostatin analogs and Lanreotide decreased tumor growth. We don't know of that in Telotristat. And finally, Telotristat is a tablet, and while there's a lot of research going on in trying to figure out ways to put these into tablets, it's not there yet. These are injectable. Telotristat was quickly picked up and received the seal of approval of the NANETS, which is the main professional society focused on neuroendocrine tumors. This was the results of a guidelines committee that met at University of Iowa, where they suggested that in patients with stable disease but suboptimal control of their diarrhea on somatostatin analogs, they thought that Telotristat was the next appropriate medication. As this issue has been covered already, there are other ways to treat the carcinoid syndrome. Various therapies that you will either hear about or have heard about. An important thing to remember is not all diarrhea is carcinoid syndrome, and Telotristat is related to that part of diarrhea that is caused by serotonin production from the carcinoid tumor. It's not going to do much good with shortened bowel after multiple surgeries. There may be some other medications that'll help with that. It's not going to do anything for cholecystectomy, gallbladder related diarrhea. It's not going to do anything for small bowel overgrowth. These are all important causes of diarrhea which need to be ruled out and thought about before considering Xermelo. You can figure out yourself, to some extent, if you can figure out what precipitates some of your symptoms, you can just try to avoid certain situations or take Octreotide somewhat before the situations to help with the diarrhea yourselves. So, in summary then, I've just discussed the key role of serotonin in the carcinoid syndrome and the role of Sandostatin, the somatostatin analogs, but importantly, this new medication, Xermelo or Telotristat, in carcinoid diarrhea. And with that, I will thank you for allowing us to talk here, and greetings from the crew at University of Iowa.
Okay, our next speaker is a medical oncologist, Lowell Anthony. We've heard from several distinguished medical oncologists already. Dr. Anthony was with the group in New Orleans for a long time, but a while back he's moved to University of Kentucky, where he's